Hello and welcome to another emergency Q&A for families in intensive care and intensive care at home. I'm your host and my name is Patrick Hutzel from intensivecarehotline.com and intensivecareathome.com. What makes me qualified to host a show for emergency questions and answers for families in intensive care and intensive care at home? I'm a critical care nurse by background. I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse unit manager for over 5 years. And I've been in critical care and in intensive care. And I've been consulting and advocating for families in intensive care since 2013 here at intensivecarehotline.com. And I can confidently, very confidently say that we have saved many lives with our consulting and advocacy. And you can verify that on our testimonial section at intensivecarehotline.com, or you can verify it on our intensivecarehotline.com podcast section, where we have done some client interviews and our clients will verify in our podcast that we've saved their loved ones' lives. We even have a patient on, an ex-ICU patient on that podcast who was told they were going to die and that they wouldn't have any quality of life and so forth, and nothing could have been further from the truth. That's why he came onto a podcast. I'm also the founder and managing director of Intensive Care at Home, and you can find more information at intensivecareathome.com. And with Intensive Care at Home, we are sending critical care nurses into the home, our critical care nurses into the home, for long-term ventilated adults and children with tracheostomies, BiPAP, CPAP ventilation without tracheostomy, tracheostomy care at home without ventilation, home TPN, home IV potassium infusion, home IV magnesium infusion, central line management, peak line management, port management, Hickman's line management, and so forth. With Intensive Care at Home, we're currently operating all around Australia in all major capital cities and in all regional and rural areas. With Intensive Care Hotline, we're consulting families all around the world in intensive care. We'll be going for approximately an hour. And I also want to welcome our viewers on replay, because I know this video always gets a lot of views on replay. So I also want to thank you for the viewers on that watch this on replay. And please ask your questions in the chat pad or connect with me live on the StreamYard link that I just posted in the chat pad. But if if there are no other questions, then I will start with the first question today, which comes from Tracy. And Tracy asks, "Hi Patrick. My husband is 49 years of age. He has been in intensive care at a specialist hospitals in London, being treated for interstitial lung disease. He's on an ECMO machine and he isn't improving, and they want to turn off his machine. He is fully sedated and his oxygen levels drop, and blood pressure rises every time they try to turn the machine down. He has been given numerous antibiotics and steroids. They say his lungs are inflamed, with only a tiny bit of lung working in both lungs, and they mentioned a stiff lung. Is there anything else I can ask them to give him or test him for? They say they can't officially diagnose anything, as they are just assuming he has this. Interesting. Any help would be appreciated from Tracy. Well, interesting comments from the intensive care teams. I mean, they can't officially diagnose him with something. That's a bit strange. Two things there. Have they done a CT scan of the chest? Have they done an MRI scan of the chest? Have they done a chest X-ray? Have they done a lung biopsy? Right? Those are the first questions I would be asking, in terms of diagnosis. If he has stiff lungs, chances are that he might have scar tissue in the lungs. If he has scar tissue in the lungs, that's probably why he would have a stiffness in the lungs and probably resistance in the lungs. Right? So, what would be next here? What would be next here is to find out the diagnostics. Have they confirmed that he's got scar tissues? And scar tissues in the lungs can be irreversible. It often is actually irreversible, right? But also, what treatment are they giving? Have they given him epoprostenol nebulizers? Have they given him nitric oxide nebulizers, right? Why are the antibiotics and the steroids not working, right? Have they tried to wean ECMO down, right? And it sounds to me like every time they do try and wean ECMO down, right, it sounds to me like when the blood pressure is rising, he probably can't breathe, which would confirm probably the interstitial lung disease and probably would confirm the scar tissue. But you can't really confirm that without a CT scan of the chest, MRI scan of the chest, or a lung biopsy, right? What's next here? At your husband's young age, I would say you should be asking whether he can be a candidate for a lung transplant, right? I have seen patients with interstitial lung disease and with stiffness of the lungs being put on a lung transplant list, and especially at your husband's young age, that should be a consideration. Should absolutely be a consideration here. Okay, so that is my advice, Tracy. You need to ask for what treatment have they tried, what has failed, what are alternatives. Would also help if we can look at the medical records. That would also very much help, right? And then we can go from there. Now, in the meantime, I encourage you to reach out to us here at intensivecarehotline.com so we can dig deeper by talking to the intensive care team directly, right? When I talk to them directly, I will ask questions that you haven't even considered asking, and I can counter ask pretty quickly. I have looked after hundreds of ECMO clients when I worked in ICU, ECMO patients, I should say, right? So I'm a subject matter expert on this topic, right? So from a nursing side, right? So that is my advice here, Tracy. I really hope that things are turning out well for your husband. Do not give up. For someone at your husband's age, he should absolutely be a candidate for a lung transplant, right? Do not underestimate that. So also want to welcome here Helene Webster is here. Thank you so much, Helene. If you have any questions, type them into the chat pad, and then we can go from there. Now, I also have a great email from Katie, actually, Katie writes a great email here. So, hi Patrick, I wanted to write you to let you know what happened with my 2-month-old nephew, in case you're wondering after my last email. So I had an email from Katie a while ago. I probably should actually go back to that original email, even though I think I read it out here at some point. I'm actually pretty sure I have read it out here at some point, but I think I do need to give you context here because it's such a great story once again that I think, where is it, Katie? Sorry guys, I will just get to it in 1 second. Yes, here it is. Here it is. Yeah, I need to give you the full context of this situation because it's been such a great story. So, hi Patrick. So this is an email actually from the 2nd of November, so it's a couple of weeks back. Hi Patrick, I found you a little too late, I fear. My brother's 2.5-month-old born, and she attached a beautiful, beautiful photo, suddenly stopped breathing 2 weeks ago and then went into cardiac arrest. He had no known health issues before that, and we don't know the cause. The hospital says it was asphyxiation with cause unknown. His mother had been breastfeeding him at the time it happened. They were in a cafe and happened to be with a friend who is a trained ICU nurse, so she gave him immediate CPR and the air ambulance came fast. They took him to Cardiff Heath Hospital, where he has been now for nearly 2 weeks. It's been a roller coaster ride of seemingly improvement and then being told he wouldn't survive, as his brain damage appeared too extensive. I've had doubts all along about the advice they are receiving because it always seemed to be directly counter to what they were observing themselves, daily improvements in my nephew as he came out of sedation, eyes opening, legs and arms moving, improvements in his breathing, etc. Then last Saturday, the doctors made a decision to give him phenobarbital and all these improvements stopped. Now, I just want to stop the email here. You should always trust your gut instinct and you should always use common sense, right? If your common sense is telling you your family member is improving, right, then you should be trusting that. Don't let anyone dissuade you from using common sense. We see this all the time. I see it all the time. ICUs are making claims that go against common sense and families don't question it, right? Always use common sense. Then last Saturday, the doctors made a decision to give him phenobarbital and all these improvements stopped. His breathing worsened and he stopped moving again. They told the parents on Tuesday that there was no hope of survival and they were in end-of-life care in an end-of-life situation now, and that he wouldn't be able to breathe on his own and would need to make the decision to turn off the ventilator. They've pretty much been saying that from the outset, so it didn't surprise me. But I do believe that the phenobarbital was still playing a big part in his lack of response and brain activity when they made that decision, especially as it's in combination with morphine and other medications. Well, I can just tell you from experience, using phenobarbital will knock people out completely, especially when given with in the combination with morphine and other sedatives or opiates. So then she can turn on. She goes on and she says, I would have shared your details with my brother, but it felt too late. He had already made his decision and they took him off the ventilator on Thursday night. He didn't stop breathing instantly as expected. By yesterday evening, he was still with us. I don't know what's happened overnight, but the expectation is that he will gradually stop breathing. So I don't think you can help us now, but I will let you know if anything changes. Thank you for the work you do. It still gives me some comfort knowing you are out there helping families in our situation. From Katie. So, what's happened here? Once again, ICUs are pushing for end of life, giving families the doom and gloom. Keep in mind, this is a 2-month-old baby. Let me ask you this. What's the hurry in killing a 2-month-old baby? What's the hurry? Please explain that to me. What's the hurry in killing a 2-month-old baby? Where's the urgency? Right? But with that email, ICU was telling them he's going to die. Well, he was still here. You have to trust, you have to immediately question their clinical judgment. Immediately. Right? So, then, this week, I get another email from Katie. And here is what Katie says in her follow-up email. And just give me 1 second. Here it is. Because with that first email, it'll probably boggle your mind what she has to say next. Hi, Patrick. I wanted to write to you to let you know what happened with my 2-month-old nephew, in case you are wondering after my last email. So this is an email from 4 days ago. So initially she writes on the 2nd of November. Today's the 17th of November for me. 4 days ago, 13th of November. So 11 days later she writes. The short story is that my nephew stopped breathing, went into cardiac arrest, and my brother's friend, who is a trained nurse, resuscitated him with CPR. An air ambulance came quickly and he was taken to Cardiff ICU, where they worked hard to save his life, and they did. From the outset, there was one consultant who made a very grim prognosis for my nephew, despite improvements that my nephew was making. He was on a ventilator, but starting to breathe more and more independently, and he had, quote unquote, woken up and starting moving a bit more every day. The ICU consultant was looking at the brain scans and the stats and saying that it was hopeless because his brain injury was too severe for him to survive. Let me repeat that because I think it is so critical in the context of this. The ICU consultant was looking at the brain scans and the stats and saying that it was hopeless because his brain injury was too severe for him to survive. He's basically saying he's too unwell to survive. So let's carry on in the email because I will come back to this statement. So then they detected seizure activity and gave him phenobarbital, which is a very, very strong sedative, very strong sedative. And after that, his breathing noticeably got much worse and he went back into a sedated state and wasn't responding. Yeah, no surprise there. 2 days after giving the phenobarbital, they did an EEG and they told the family that he had almost no brain activity and that his brain could not even sustain him breathing on his own. They were told it was end of life and they needed to make the decision. They needed to make the decision to turn off the ventilator where they expected him to stop breathing straight away. How the language that Katie is using here really is very disturbing to me. Basically, the ICU says to the family, you need to make a decision to take your child off the ventilator. That's gutless. That is heartless. And people need to be called out for it. Right? Once again, what's the urgency here to kill a 2-month-old baby? Please explain that to me. So, but it gets better. When the parents agreed, the ventilator was turned off and all treatment was withdrawn and a DNR put in place. That was 2 weeks ago. My nephew did not stop breathing. So the intensive care specialist was completely wrong in his misjudgment, in his clinical judgment. Completely wrong. He carried on breathing on his own. The hospital stance remained the same. They withheld all treatment and said he was just taking a longer time to die. They refused to reassess him. The parents requested a transfer to another hospital in Cambridge as they didn't live in Cardiff and were effectively homeless as they were in the middle of moving to Spain when this happened. My sister-in-law's parents live in Cambridge. The hospital agreed to the transfer on that basis. My nephew arrived in Cambridge Hospital on Monday, and this was him yesterday. She sends another cute picture. He's no longer in ICU and he's on a children's ward. He is being reassessed and receiving a lot of different types of care, including neurology and physiotherapy. I want you to know that I found your site and newsletter the day the ICU turned off the ventilator. It made me realize the difference between real and perceived end-of-life situations. And I realized the whole prognosis was based on theory, stats, and an EEG done while he was probably still affected by the phenobarbital. I talked to my brother and he did his own research and he did manage to delay the ventilator being turned off by 1 day, which may have made the difference what saved him. So you helped us indirectly, even though we never had time to consult with you. I'm very grateful that you exist and that you are helping families like ours. Best wishes from Katie. Well, Katie, thank you so much for sharing this story. I think this is so important for everyone to hear who has a similar situation with a family member in intensive care. I cannot stress enough that when 90% of intensive care patients survive, and that's the stats, that's the research, right? Why should your family member be the 1 out of 10? Right? Why? Please use common sense. Do not let intensive care teams' rhetoric dissuade you from using common sense. Right? Common sense is no longer all that common. But the bigger question here is why would intensive care teams say, well, he's not going to survive, it's hopeless. Those were the words used in Katie's email. He's hopeless, he's going to die, it's just a matter of time. And then he survived. Why would they do that? Well, there's a number of reasons why they want to do that. Number one, let's talk about the worst case scenario for intensive care teams. The worst case scenarios for intensive care teams is to look after a patient in ICU indefinitely with an uncertain outcome. That's at least what their perception was. Imagine they would have treated this little boy properly. He's making progress without having received proper treatment because they said he was a hopeless case. Imagine how much progress he would have made by now if he had received proper care and treatment. Right? It is absolutely alarming that intensive care teams are doing this. It is absolutely alarming. But in the UK, because this is an email from a UK subscriber, I am not surprised. I mean, you look at the cases in recent years, Alfie Evans, Charlie Gard, Archie Battersby, and there were others that died in ICU because the NHS and the teams there were absolutely negligent, refused to fly those kids out into other countries where they could have continued with treatment. It is absolutely appalling. Absolutely appalling. Right? And here, in this situation, thankfully, this little boy turned the corner, by himself. And maybe that day, that your research delayed extubation, maybe it saved him, maybe it didn't, maybe he would have survived anyway. But for anyone watching this that has a family member in intensive care, please keep in mind, approximately 90% of intensive care patients survive. That's 9 out of 10. So why should your loved one not be surviving? Because the odds are in your loved one's favor. Keep that in mind at all times, please. Okay, so, but why are ICUs doing that? Well, like I said, they want to stay in control. Who lives and dies? That's very concerning. It's extremely concerning. That's number one. Number two, they need ICU beds as quickly as possible, right? And they don't care how they free up the ICU beds. If it means someone is going to die, well, so be it. Number three is they want to save cost. A long-term stay in ICU with someone with an uncertain outcome is extremely expensive, right? Extremely expensive. And they don't want to put in the time, the resources, the emotion, right? To to do what is right. To do what is right. Right? And number 4, let's just say, a patient like this needs long-term care, right? Let's just say they need long-term medical care, long-term nursing care, whatever the case may be, right? That's cost. And I do believe that doctors and nurses in the NHS have now been educated to save cost. It's terrible. It's no longer about the human aspect. It's no longer about the people we're looking after. It is now about, minimizing cost, which is terrible. Terrible, terrible, terrible. Okay. Now, before I move on to the next email, type your questions into the chat pad or connect with me live on the show here. And you can connect live on the show with me here through the StreamYard link. Right? So I put the StreamYard link in the chat pad and you can talk to me directly here. You don't have to go on camera. You can just stay behind the camera if you want, but you're welcome to get on camera and talk to me and I can answer your questions right now. If there are no questions, then I move on to the next email that came in during this week from Sonia. And it's actually Sonia Popovic, and she writes this email on the 9th of November. It's also live on Sonia Pop Data Bank, which I believe is her own website. Anyway, I know that Sonia had a family member in intensive care because she contacted me a while ago, and I know it was pretty dicey at the time. I hadn't heard from her. She only reached out to me after the situation was done and dusted. I believe her family member, her mother, actually passed away. And she writes on her blog and in an email, and I'll read this out to you. I don't have all the context, but I'm sure I will get the context as I go along. I do believe it has to do with end of life in intensive care and with feeling mistreated. Sonia Popovic. The topics that she puts in the email is Ativan, AFib, Alzheimer's discrimination, autopsy, cardiac arrest, close the deal, daughter's rights, DNR, elder abuse, end of life, extubation, father in denial, healthcare system, hospice frauds, hospice monopoly, hospital death count, ICU, kickbacks, lawyer, memory care bias, mistreatment memory care bias, morphine, nurses need raises, philanthropy, quality hospital payments, quality of life space, treatment cutoff, inhumane, uncooperative father. Notes, idea. To have hospitals not operate on a sliding paying scale of equality to where the death count matters, for all doctors and care operate on the same level, equal good standard care. Hospice just pushed us to get my mum with them. Hospitals are losing money, plus incentives and kickbacks are putting their studies in liability for what? Hospice is a disgraced drug-induced forced death with incompetent medications that have more side effects than comfort. Right. Now let me say this here. You are saying in your email, hospice just pushed us to get my mum with them. I disagree there strongly. No one can push you. So that is something you let happen to you. I'm sorry. I'm a strong teacher here. No one can force you to have your mum go into hospice. We've had so many clients avoid hospice. So many clients over the years. We have saved so many lives with our advocacy and with our insights, right? That I strongly disagree. You let hospice push your mum into end of life. That's how you need to look at it, unfortunately. I tell you who are the best families who get outcomes in intensive care. Families who get outcomes in intensive care and who get what they want is they take full responsibility. They take full responsibility of what's happening. And if you phrase it like you have let hospice push your mum into going there, that is your own fault. I'm sorry to say it. That is your own fault. We have saved many, many lives with our advocacy. You can verify that at intensivecarehotline.com at our testimonial section or on our intensivecarehotline.com podcast where we've done client interviews. Okay, let's carry on with her diary there. Also, there may be some breakthrough cuts off to death. By not continuing standard, and she puts care in quotes, by not continuing standard care treatment, cutting off the opportunity to perhaps overcome some miracle would be cutting off the unlimitless possibilities of discovering a new way or pathways that the human body and spirit may have to offer. I agree. I fully agree there. This is in the case of my mother, for example, where she got better when we took her off lignocaine and couldn't verify that the lignocaine was putting her in a coma, unresponsive states. Meanwhile, hospice is recommended because she puts quality of life in quotes. Their quality of life judgment was bestowed on a push, but also a push for death counts and hospice promotion push. Yep, agree with all of that. Well, quality of life judgments should come from you, not from them, right? You've bought into their frame. You've bought into their narrative. Once again, you need to take responsibility. You need to create your own frame and your own narrative. Two components that have very limited good outcome for us all as humanity in the outcome of things. So as she's getting better, just finally we are pushed for another meeting with hospice. No, you're not pushed for another meeting with hospice. You have decided to be pushed for another meeting with hospice. You should have never gone to the meeting in the first place. Never. So, I'm grateful you've reached out to us, but I'm also pointing out for anyone watching this where you went wrong. Right? I'm the drill sergeant here. I'm sorry. Right? And this is tragic beyond anything. But you can't have this tragedy repeat. So listen carefully what you should have done. This is a warning for anyone who's in a similar situation. So again, I'll just repeat the last sentence. So as she's getting better, just finally we are pushed for another meeting with hospice. No one can push you for a meeting with hospice. If the ICU team asks you to jump off a bridge, would you jump off a bridge? No, you wouldn't. So why would you go to a meeting? To give them a platform? To repeat their end-of-life requests? Why would you give them that platform? Once again, use common sense. Okay, then she continues. Promise we can check her medications before anything. We'll rush for terminal extubation as she's waking out of intoxication. Meds were not considered as soon as they had my dad's signature. I was completely ignored as she rushed into a procedure to flip the charts, as they call it. They didn't wait till after she extubated. That's the life support breathing tube in the ICU. Well, it turns out she did her excavation. Not generally, she did it successfully and was breathing. Hospice was during her up right away for her death. So then Sonia continues. What we didn't get because my dad was pushed into hospice early that day, when there's no need to rush. Exactly. How many times have I said just today, what's the rush and the urgency to kill someone in ICU? Please explain that to me. Where's the urgency to kill someone in ICU or in a hospital? Please explain that to me. Then she continues. The promise to grant wishes to have meds looked at beforehand were completely forgotten and ignored. Told no after signing. Disregarded suddenly. Okay, Sonia, here's the missing link. You should have requested access to medical records. Why did you not do that? Because then you could have looked at what's written up. Right? Once again, I'm not trying to be harsh. I'm just telling you what works. Families in intensive care that get results take responsibility for outcomes. They take responsibility for everything. Right? And they get the right help. Then she continues. Promised to transition after extubation if she was going to live through it. Need to wait another day for mum, was just coming out of her coma-induced state, until she met the hospital legal requirements for extubation rules, and promised to do so was suddenly not in the cards. Then extubation was rushed. Just for anyone watching this who's not familiar with the term extubation. Extubation means the removal of the breathing tube. It means the removal of life support. Then Sonia continues. No assistance post-extubation from my mum, now denied, such as no. No assistance to suction out extra saliva because they consider that treatment and not comfort. Now was told otherwise. Was told the procedure would go as normally, that they're just there for added comfort. Wow. Okay, let me break this down and let me read out this section again and let me break this down for you what that means. No assistance for suction out extra saliva because they consider that treatment and not comfort. Now was told otherwise. I was told the procedure would go as normally, that they are just there for added comfort. So that very much sounds like bait and switch, right? Well, on the one hand, they were telling you about hospice, but they were telling you they would consider some form of treatment. Then they took out the breathing tube, and then you realize there was saliva building up. She needed suction. They refused that. She would then automatically probably swallow saliva into her lungs, i.e. aspirate, because she was too drowsy, and she would basically suffocate and drown in her own secretions. What a cruel death. What a cruel death. But once again, you haven't done enough research, you know. You haven't done enough research. You didn't get the help you need. So then she continues, whereas they took the comfort of her feeling better to get stronger for the procedure, gave her medicine instantly to promote her death. Yes, they would have. That's what hospice is there for. Hospice would give her morphine, midazolam/Versed, fentanyl, maybe propofol, maybe some glycopyrrolate, all medications to help aid the death process. And one could argue that's a form of euthanasia. Other, stronger points of view might argue that's murder. You know, just putting it out there. Just putting it out there. Right? So, then Sonia continues. Didn't have her feet covered with a blanket, just one thin sheet all night long. Didn't get assistance of breathing machine. That's denied now as well, of course, if you extubate her. So here's the problem. Here's the problem. Again, the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care. And the situation has been mismanaged all the way along because you didn't know what you didn't know. Well, when your family member has the breathing machine removed, you already need to have negotiated with them that the breathing tube will be reinserted in case your loved one cannot breathe independently. So you've missed the boat, didn't do the research. So you can't blame them because they're doing what they're doing, right? They're doing what they're doing. They have no interest in keeping your mom alive. You need to be the advocate. So then, didn't get the assistance of the breathing machine. That's denied now as well, given meds that cause respiratory distress, respiratory depression from both medications. Yeah, she would have had some midazolam Versed and some morphine or fentanyl. All of them are known to have respiratory depression as a side effect. Of course, it'll hasten death. Then the Sonia continues, unnecessarily transferred her too early for no reason. Talk to your doctor at hospice. But no surprises there. Doctor at hospice can't do anything. No, because you had signed your life away. Denied the right to have doctor at hospital talk to her pharmacokinetics the day of transport because she was on hospice and moving her already. Doctor from hospice had no compliance to talk to pharmacokinetics, and next day just put cancel on all meds as if I ordered that, knowing I discussed it but didn't order that, also knowing I didn't have the right. But my dad did. Game playing on delay, which affected a delay of 2 hours while she was painfully gasping for air. They said they'd be right back for pain medicine, didn't show up or bother, but when talked to them upon arrival, they said there was a no medication order. Then had to I get the order, took another hour and a half, and have yet orally, not intravenously, and died within the next hour. didn't give her the other medication, Ativan. Well, you don't want the medication Ativan because Ativan would have also hastened her death, right? Would have also hastened her death, right? Ativan is a benzodiazepine and also has the main side effects of respiratory depression, right? It is a very sad situation here, Sonia, right? But, you know, if you had just read my blog, you would have known what's to come. Just by you reading my blog, you would have been prepared, right? Of course, if you had engaged me directly, I could have helped you even more. You know, that's what we do successfully. We have helped so many families in intensive care saving their lives, right? You know, there's a quote somewhere that says something like, if you are faced with an impossible situation, you don't need the muscles of a Hercules. You don't need the mind of an Einstein. You just simply need to know what to do. And, you know, we know what to do. So then Sonia continues, denied honest, fair game, whereas no doctor at the hospital would ever turn a conversation from the day before go suddenly be in order to stop meds by unauthorized family member. It was clearly discussed with my dad. Well, I tell you something, and it might sound very harsh what I'm saying now. Life isn't fair. And everybody knows that. Now you can get bogged down by that, and you can swallow, you can, you know, be feeling sorry for yourself that life isn't fair, right? Or get over it and take action. Life isn't fair. Take action instead. That's my advice. And don't let life not being fair bog you down. It's working against you. Next, Sonia continues, discrimination of Alzheimer's to prejudge quality of life. The persistence and push from hospice is disgraceful. Lakewood Ranch Medical Center uses Tidewell, the monopoly of no choice and disregard to family wishes. Again, I disagree there. Whilst I agree that Alzheimer's has probably been used to prejudge perceived quality of life, I agree with all of that. But you also bought into their narrative and you bought into their perceived level of control. You know, always think for yourself, always create your own narrative, always question, and don't let the perceived power of someone intimidate you. You cannot control other people, but you are 100% in control how you react. You're 100% in control how you react. If you react with passiveness and with being intimidated and let them get on with their show, you have to take responsibility for that. Next, the plan of care wasn't written out after asked repeatedly for something in rewriting. Sure. Again, that could have been escalated to hospital executive, right? Once again, you didn't know what you didn't know. We are writing letters and emails to hospital executive all the time on behalf of our clients with very much success, a lot of success. Next, she continues, redirected or had to go to the medical public relations department to figure out a way to get something in writing, like their policy of procedure or procedure during extubation. The medications were discussed every time in meetings, but not that it mattered to them, and patient rights. Anything my mom doesn't have the CYP2D6 genes affecting her metabolism of drugs. In addition to the fact that my research and her one chart proves that Ativan and morphine is not best for mom, of course not. Of course it's not best for your mom. Ativan and morphine have a huge sedative effect. A huge sedative effect, right? I was under the impression or told that they don't induce death. Well, why did you not do your own research? However, My mum granted she survived the extubation, should have been cared for without heavy death and during medications. Whereas I was told that they are there to assist my mum in any pain, and the 6-month terminally ill decision was chosen by my dad's choice because the doctors could not legally say she has 6 months or less to live, leaving us with a choice on his hands unnecessarily. I was told to get her medical records myself. Her death was painful, disgusting. They starved her to death, and I know they stepped in, not being able to say too early. What they did was interviewed on her being cared for, to turn into torture, discomfort, elongated, unnecessary death. Sonia, this is an incredibly sad story. And I know I'm being harsh here with what I'm saying, with some of the things that I'm saying. But, with the right research, with the right support, we have saved many lives for our clients in ICU. It's all documented in our testimonial section. It's documented in our podcast. If you're faced with an impossible situation, which those situations often seem quote unquote impossible, you don't need the muscles of a Hercules. You don't need the mind of an Einstein. You simply need to know what to do. We know what to do because we've been there, done it many, many times. But thank you for sharing anyway. Really, grateful that you've shared this, because, it's a good learning experience for anyone that's watching this, And at least now you know what to do. If you're watching this and you're in a similar situation, you know what to do. You know what to do. Now, don't let intensive care teams intimidate you. Go in there with your head held high. Show them with your body language that you mean business, and educate you on your rights. You have rights. You have rights. You just need to exercise them. Right? You just need to exercise them. Okay, now before we move on to the next question, please type your questions into the chat pad, or connect with me here live on the stream. Here's the StreamYard link. You can connect with me live here, and you can talk to me directly, and I can answer your questions here live on the show. If you just want to listen in, I will continue with the next question from Christy, who says, "Hi Patrick, my dad is in the ICU for pneumonia and kidney failure. He's given 2 options. Number 1, to die naturally. Number 2, get a tracheostomy, go to the rehab center with no guarantee of coming home. How can I advocate for my dad? We tour the rehab facility and it's depressing. Please advise." Thank you, Christy, for writing in. So first question is, have they cleared the pneumonia? That's first question. Next question is in kidney failure. Is he on dialysis or on hemofiltration? Those are very important questions to consider, right? The next question is, they are talking about tracheostomy. And I know that giving you the doom and gloom spiel, they're giving you the negativity that there's only 2 options. One option is to die, what they refer to as naturally. And number 2, get a tracheostomy and go to the rehab center. So I know by you saying that you are in the United States. So, you remember, I've said on this podcast today many times, 90% of intensive care patients approximately survive. That's 9-0. That's 9 out of 10 survive. Why should your dad be in the 10% bracket of not surviving? Right? And What have they done to this point to avoid the tracheostomy? Is there any chance to get him off the ventilator and the breathing tube in the first place? Let him wake up, right? And let him survive without a tracheostomy. Now, they haven't given you that option, and maybe it isn't an option, but you need to ask the question anyway. Is he not waking up because he is too sedated? Too many sedatives on board, too many opiates on board, and have they tried to wake him up? Right? Right? Now, if he does need a tracheostomy, which is also a possibility, then you don't have him to go to rehab. You don't. So, two things here. The first thing is, if he needs a tracheostomy, they probably also want to push you for a PEG tube. Okay? If they're going to push you for a PEG tube, my advice is not to give consent to a PEG tube. That would be my strong advice. Right? I'm not going to do too much detail here now why no PEG tube. I've done countless of videos about this. Why no PEG tube? Right? Then, if he does need a tracheostomy, then he should stay where he is, so that you or that your dad can be weaned off the ventilator and the tracheostomy while he's in ICU. They are best equipped to wean him in ICU. They've got all the expertise. Those rehab centers / LTAC are dangerous, dangerous, dangerous places. I made a video a few months ago, 10 reasons why LTACs in the US are a scam. And I encourage you to watch that video. In any case, once again, if your dad needs a tracheostomy, just keep him where he is. No one can force you to discharge him anywhere. And if he has a tracheostomy and a ventilator, he will need ICU care anyway, right? And they can wean him off there. That is what you should be aiming for. Now, just quickly coming back to the end-of-life aspect, or potentially real or perceived end-of-life aspect of your dad's situation. What does your dad want? We can talk about options here all day long. You haven't shared how old your dad is. You haven't shared what he would want. Your decision should also be driven what your dad would want. Right? That's also very important. What would your dad want? Okay. Very important consideration, I believe. Okay. Helen, you're saying, no one informed fentanyl would end my mum's life, but was illegally prescribed to control iatrogenic personal injuries from excessive use. BiPAP machine, causation excessive saliva glands, and cut esophagus. Not entirely sure what you mean. I can understand that, if they haven't told you about the BiPAP, if they haven't informed you that fentanyl would end your mum's life, it probably depends on how much fentanyl, right? Probably depends on that. How much fentanyl, Okay. Now, do you have any other questions? Are there any other questions? Please type them into the chat pad. I would have time for another question. Or if you want to quickly connect with me here on the live stream, then talk to me on the live stream. But I'll be wrapping this up in a minute. Right, I will be wrapping this up in a minute. I have another email here from Kallio, who says, I don't know the full truth to what's really going on for my family member in intensive care. I can see that. I can see that. And if you don't know the whole truth for what's going on in ICU, that's why you need a second opinion. That's why you need consulting and advocacy. That is why you need someone that can break down for you what's happening in ICU with your family member. That is what we do here at intensivecarehotline.com. That's all we do, you know. And once again, you need to take responsibility for the outcomes for your loved one. You absolutely need to take responsibility. Now, another question that comes in from Jason here is, can you assist me about the gag reflex when you have a tracheostomy in your throat? Not entirely sure what you mean with that question, but if your loved one has no gag reflex, that is probably one of the reasons why your loved one had a tracheostomy in the first place, right? Probably that's why your loved one probably needs a tracheostomy in the first place, because they have no gag reflex. If someone has no gag reflex, that means they can't protect their airway. And if someone can't protect their airway, that means they can't swallow, you know, and that's why they need a tracheostomy in the first place. That is most likely what's going on here. You know. Now I have another email here from Princess who says, I've been told that my loved one may not survive and they want to turn the machine off. Once again, how many times today and in other videos has there been a misjudgment from ICU teams, right, about end of life, and them saying, well, your loved one is definitely not going to survive, and then they do survive, right? You have to question everything. You have to question everything. Okay, so I'm going to slowly wrap this up for today. If you like my videos, subscribe to my YouTube channel for regular updates for families in intensive care. Click the like button, click the notification bell. Share the video with your friends and families. And I really want to hear your comments. What do you think? Do you agree with the things that I'm saying? Do you disagree? I'm happy for all opinions, right? I just want to know what you think, right? With Intensive Care Hotline, like I said, we've been helping hundreds of members of clients. You can look at our testimony section. You can look at our podcast section. We have helped so many families in intensive care to save their lives, right? You know, you don't need to buy into the intensive care team narrative. You have a choice, but you need to make a wise choice. That's why we have a membership for families in intensive care. You can get access to it at intensivecarehotline.com. I do one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp, whichever medium works best for you. I talk to you and your families directly. I talk to doctors and nurses directly. I handhold you through this once-in-a-lifetime situation that you simply can't afford to get wrong. I also represent you in family meetings with intensive care teams. We do medical record reviews in real time so that you can get a second opinion in real time. We do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. With intensive care at home, like I said, we are sending our critical care nurses into the home for long-term ventilated adults and children with tracheostomies, home BiPAP, home CPAP, home tracheostomy care without ventilation, home TPN, central line management, peak line management, Hickman's line management, as well as port catheter management. With intensive care at home, we're currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. We are NDIS approved, TAC and WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland, DVA all around the country. We have also received funding through public hospitals, private health funds, departments of health, and so have our clients. We also provide level 2 and level 3 NDIS support coordination. If you're an ICU specialist, ED specialist, please reach out to us as well. We can help you eliminate your bed blocks in ICU, ED, etc. And if you're a hospital executive watching this, we can help you eliminate bed blocks in your ICU, ED, etc. Now, thank you so much for watching, everyone. I'll be back next Sunday, 10:30 a.m. Sydney, Melbourne time, which is on the day before Saturday evening, which is 6:30 p.m. Eastern Standard Time and 3:30 p.m. Pacific Time. Thank you so much again for watching. This is Patrick Hutzel from intensivecareathome.com and intensivecarehotline.com. Have a wonderful week. Take care for now.